Hello, everyone. Welcome to the Alamo Breast Cancer Foundation Advocate Chat. My name is Ashley Dedman, and I'm a trained breast cancer research advocate. And I'm here today with Dr. Sebastian Winnicor with Baylor College of Medicine. Thank you for your time this morning, Dr. Winnicor. Let's dive right in. Can you share a little bit more about yourself before we dive into today's topic?
Yes, thank you. Thanks for having me, Ashley. Really appreciate being here. So I'm a board certified plastic surgeon at Baylor College of Medicine, as you mentioned. I'm currently the interim chief of the adult plastic surgery division. I subspecialize in breast cancer reconstruction. I've done, in terms of my training, I've done special microsurgery training in breast reconstruction. So this is the focus of my training is to help me practice in my specialty, and I've been in practice for 7 years, all at Baylor, and it's with great. It's a truly humbling experience to be able to do what I do and look after breast cancer patients and perform the surgeries that I do to help people move on with their lives and restore their well-being.
Well, we thank you so much for your commitment to this work and commitment to your patients. And I know for the topic today, I know you're familiar with the concerns of women facing reconstruction or not. Some women don't choose reconstruction after breast cancer surgery, in addition to women who also undergo prophylactic or preventative reconstruction surgeries as a result of being high risk for breast cancer. And so we're going to dive right in. Can you tell us a little bit more? We know that after a woman is diagnosed, that the conversation around treatment is a conversation that she and her family and caregivers begin to have. And so can you talk with us a little bit more about reconstruction? Is reconstruction typically the only treatment? Is it accompanied with other treatments? What does that typically look like? What does that path look like as a woman begins to embark on her treatment options?
So it's a really good question. Obviously, it's an overwhelming diagnosis when a woman's diagnosed with breast cancer. And the most important thing, I think it's important to impart on whoever that patient is that your care is going to be delivered by a multidisciplinary team, of which a plastic surgeon is just one member of that team. You're going to have a medical oncologist, a breast surgeon, a radiation oncologist, and perhaps a geneticist, and a plastic surgeon. So you have a team that surrounds you to help you along this journey, because it can be overwhelming, and it's a journey that's going to take some time for you to overcome this. But nevertheless, there are options for reconstruction, and I think that's the most important thing to really relay to patients, is that you're not alone, and some people are going to guide you through this journey. And so, as you mentioned, there are a variety of different aspects of the treatment course. Surgery is one of them, and it's usually a fundamental part of the treatment. But there's medical oncologists that may recommend chemotherapy. There's radiation oncologists that may recommend radiation. And the decision for breast reconstruction is a personal choice, and there are options for breast reconstruction, but there's also options for women not to go undergo reconstruction. And through a variety of consultations, this decision is usually made with the provider, and what we call the shared decision, where I, as a plastic surgeon, try to give the information, empower the patient themselves to be able to make a decision that's right for them after they've not only met with their providers, but discussed the situation with their families and their loved ones and their friends so that they can make the right decision for them.
I love that term shared decision. I think that's so important. I know I had in December 2016 a prophylactic or preventative double mastectomy due to being a BRCA2 mutation carrier. And my plastic surgeon had that same presence of really making it a shared decision. I was very apprehensive and very nervous and had a lot of concerns. And when you said shared decision, that really took me back to that time where I was having those collaborative and bi-directional conversations with my surgeon. So that's definitely important, making sure that the patient voice is really elevated and heard. So thank you for sharing that. Just a little bit more. I heard you say chemotherapy and radiation. Does reconstruction interfere with chemo or radiation, or does chemo or radiation impact reconstruction?
Well, it's a good question. I mean, there's no question that both of those treatments impact reconstruction, and the options for reconstruction are impacted by those treatments. So it's an interplay between the two. And so at the end of the day, the treatment of the cancer comes first. And we work around that treatment to try to deliver options for reconstruction that minimize complications, minimize patient morbidity, and try to achieve the very best in restoring the form and the function of the breast that's being affected by the cancer. So some options for treatment are not good options in the face of radiation, for example, and some options are very good options, for breast reconstruction when somebody's going to need radiation. So it really depends on the specific situation. Things like when radiation is going to be delivered and the time, and we deliver a treatment plan and a reconstruction plan around the timing for that, so that we can optimally achieve the best results for our patients.
Absolutely. Can you share with us a little bit more about the different types of reconstruction, starting with a diagnosed woman, but then also talking about reconstruction options for the undiagnosed woman who decides to have a preventative double mastectomy to lower or reduce her risk?
Yeah, for sure. So there's really two categories of surgical treatments of breast cancer, really what we call lumpectomies, which are traditionally linked with radiation treatment, and mastectomy, which may or may not involve radiation treatment. And that is really going to be determined by the breast surgeon, the medical oncologist, and the radiation oncologist. The treatments for a lumpectomy for breast reconstruction are different than the treatments for a mastectomy. Lumpectomies traditionally are what we refer to as breast conservation therapy, where we are trying to restore the shape of the breast from the area that's been removed, and that can be done by a variety of different techniques, either local tissue rearrangements or removing breast tissue around to fill in that area, or combined with procedures that either reduce the size of the entire breast or just lift the breast to give it a more restored youthful appearance. Mastectomy treatments are very different. You can divide those reconstructions into really two categories. One would be using implant-based reconstruction, and the other one would be using your own tissue, that the medical term is autologous, auto being taken from the same person and using that to restore the breast. And so the patient will make that decision with their multidisciplinary team, which treatment is right for them, because not every patient has both options. And then once a decision's been made, and taking into account the options for reconstruction, they can formulate a full treatment plan that includes the reconstruction later on.
That's definitely very, very helpful. I know as women are beginning to prepare for surgery, I know there was an article that now we're noticing or seeing a lot of women who are deciding who are having a mastectomy, but not having or deciding not to have implants or to have their breasts reconstructed, but are deciding to go flat. And I love how you said, it's the patient's choice, and really empowering that patient and elevating that patient's voice. Can you talk with us a little bit more about the decisions that women are making to remain flat?
Yeah. So a decision for either having breast reconstruction or not having reconstruction is really a personal choice. And we're as plastic surgeons, we're here to support and empower the patients so they can make the right decision for them. If that decision entails not proceeding with reconstruction, there are still options to try to minimize the negative appearance of not having a breast. So for example, a plastic surgeon may be involved in the treatment after the breast surgeon has completed the mastectomy to try to minimize any excess skin that's on the chest wall. Sometimes we see excess skin towards this midline of the chest wall or towards the armpit area. We also try to minimize any excess hanging skin so that the chest wall and the area where the breast was is completely flat. And so women don't have to deal with having excess skin hanging off the fold where the breast originally was. So I think that is an ideal option for patients who are choosing not to have reconstruction, such that we can maximize what they're trying to achieve and down the road not require any further surgeries, and they can move on with their lives.
That's very interesting. So I'm going to pivot. I know that there are women who choose to not have implants or have the full reconstruction of the breast. And then there are women who decide to either have a deep flap or have implants. Can you talk to us a little bit more, or even fat grafting? Can you talk to us a little bit more about the different options of the reconstructed breast and the pros and cons of those options within wanting to undergo the reconstruction part to redevelop the shape of the breast?
Yes. So what you're referring to is is the options for reconstruction following mastectomy. And as I mentioned earlier, there's really two big categories: implant-based reconstruction and what we call autologous, or using our own tissue. Implant-based reconstruction is a simpler option. The surgeries are generally shorter in length, and many of the surgeries can be performed as outpatient surgeries. They typically are performed in a two-stage reconstruction, usually with a tissue expander placed at the time of the mastectomy, or what we refer to as immediate reconstruction. And then we allow the breast skin, which is usually taken a little bit of a hit from the surgery, to recover over the subsequent 2 weeks before we start an expansion process where we re-expand that skin over the subsequent 2 or 3 weeks in anticipation of the final reconstruction. That final reconstruction, if we are discussing an implant-based reconstruction, is either a silicone or a saline implant, but traditionally we use silicone just because of the benefits associated with the superiority, I would say, of silicone implants over saline implants. And we remove those tissue expanders and replace them with implants, usually about 3 months down the road or later. And that's typically a day surgery and a simpler solution, which may be the right solution for many patients. The other alternative is using your own tissue. And there's a few options for using your own tissue, but pretty much the gold standard today is using abdominal-based tissue, or what we call a DIEP flap, which is an acronym that's based on the anatomical blood vessel that supplies the flap. And that flap is your own natural skin and fat. It's taken during a surgery that can last anywhere between 5 to 9 hours, and that surgery is done under the microscope, where we hook up those blood vessels, 2 blood vessels in the chest, to try to move that tissue from the belly to the breast to restore the breast form. The loss of tissue on the belly results in a hip-to-hip scar that's very similar to a tummy tuck scar, and the tissue that's transferred to the breast really restores the breast in the most natural way possible, because that is your own tissue. I usually counsel patients that once they've recovered from that DIP flap, they typically require some sort of revisional surgery at the earliest 3 months later, just to do the touch-ups of nips and tucks, scar revisions, and other small minor procedures, just to maximize the aesthetic appearance of the reconstruction.
No, this is very helpful. I'm going to dive in a little deeper, even within these surgeries. I know there's questions about nipple sparing and nipple reconstruction, nipple tattooing. I know when even as having a prophylactic or preventative mastectomy, my surgical oncologist talked to me about the risk of potentially losing my nipples during the surgery. And I know, and then also losing the sensation. And I know currently almost, I had it in December 2016. I don't have any feeling in my breast. I think I've gotten feeling back over the years. And then I know after surgery, I was at risk of losing my right nipple, but luckily I was able to keep it. So can you talk to women and talk to us about, I know all paths are different, all journeys are different, every diagnosis is different, every treatment option is different. But these are questions that women have. What will it be like on the other side of having a mastectomy? So can you talk to us about nipple sparing mastectomies? Mastectomies where the nipple has to be reconstructed, and then also those options for tattooing during these procedures.
Yeah, absolutely. So nipple reconstruction is a personal choice. So I think whenever we have an opportunity to preserve the nipple areola, I recommend to do that, because it has such a profound impact on the aesthetics or on the aesthetic appearance of the breast. A nipple-sparing mastectomy restores the normal breast to the best that we can restore it. And so when there's an option for a nipple-sparing mastectomy, I generally recommend it. Some women, for example, in a prophylactic mastectomy, there may be more options, as the patients are typically younger, and the nipple position is generally in its normal position in the preoperative setting. But for some patients, the nipple position may be too low. And in that situation, what we call a skin sparing mastectomy, where we have to remove the nipple, may be the only option, especially in somebody who has a low nipple position and has active cancer. Nevertheless, doing a skin sparing mastectomy still leaves options for nipple reconstruction down the road. Those options have never been better as the technology has gotten better. For example, we can reconstruct a projecting nipple should the patient choose it at the end of the reconstruction. That projecting nipple can an areola can be reconstructed around that using three-dimensional areolar tattooing, or if the patient chooses, the entire nipple areola can be reconstructed with three-dimensional areolar tattooing. So the technology has continued to become better. And I typically will show patients photos of what a three-dimensional nipple areola will look like. And in many cases, the appearance may not even be differentiated from a normal appearance from a distance. So it's quite amazing how the technology has improved. But nevertheless, I think when there's an option to preserve the nipple, that's the best choice in order to try to maximize the aesthetic appearance of the breast.
And I know the last thing you touched on was that appearance. And so that really takes me into when having a mastectomy, and I know there's different types, different women. Typically, and I know with so many medical advancements and medical updates, I know the way that mastectomies were performed years ago to the way they're performed now. What does typically that incision and that scar, what does that usually look like? What does that pain look like? What does that recovery time look like? Can you help us understand just how far we've come in this process medically, and what women can expect as it relates to incisions and scarring and healing and recovery?
Well, there's been a tremendous change in terms of our knowledge of the treatment of breast cancer. 50 years ago, the surgeons would typically remove the pectoralis major muscle with a reconstruction like this. Today, we're talking about breast conserving therapy, where we are able to do a lumpectomy in many cases and preserve much of the breast. Nevertheless, when a mastectomy is necessary or the patient has made a decision for that, there's still a variety of options for incision location and appearance. So, for example, in a skin-sparing mastectomy incision where the breast has been removed and the nipple areola needs to be removed, either a horizontal or a vertical incision are typically what the appearance of the scars will look like. So a horizontal incision would be across the front of the breast, where we try to keep the incision off the cleavage area, or a vertical incision from where the nipple areola was down to the fold of the breast would be the two traditional incisions. When nipple-sparing mastectomies, my preferred incision, this really depends on the close working relationship that plastic surgeons have with the breast surgeon, would be an incision along the inframammary fold or hidden under the breast. But there are other options for incisions for even with nipple-sparing mastectomies, including around the areola with lateral extensions into the armpit, or a less commonly used vertical incision. But I think that for my personal preference, I think that an incision that's hidden along the inframammary fold is the most aesthetically ideal, gives the best access for the breast surgeon to perform the procedure, and also gives a really good option for a second stage of the reconstruction when we go in either to put in an implant or to put your own tissue in, as we previously mentioned.
Wow, that's very insightful, Dr. Winocor. I know that we discussed women who elect to have the aesthetic flat closure. I know we talked about fat grafting and the deep. I want to talk about women who decide to have an implant. And I know there's silicone, there's also the saline. Can you talk to us about, when talking about an implant, typically the different types, what aesthetically that looks like, kind of the pros and cons of that within the implant focus?
Yeah, so there's really two types of implants that we talk about, silicone and saline. So silicone implants have been around for 50 years. First implant was placed here in Houston in the early 1970s. Wow. And so at this point, we're on the 5th generation of implants. We talk about cohesive gel silicone implants, which means that they're kind of like a gummy bear, so that just like if you break off a piece of a gummy bear, the gummy material doesn't leak out. Just like the latest technology in silicone implants are very similar. So if the implant was to rupture, the silicone would not leak out as previous generations have. So cohesive gel implants are pretty much the standard now for silicone implants. Saline implants, which are typically used in breast augmentation surgery, are used less in breast reconstruction. A saline implant has a silicone shell and it has salt water in the center. One of the advantages of a cohesive gel silicone implant is that there's less rippling associated with the implant. And so, unlike in breast augmentation surgery, where implants are placed under the breast tissue or even under the muscle, that tissue camouflages any rippling. In breast reconstruction surgery, because the breast has been removed, there's really no forgiveness for rippling. And so we really want to be using implants that have the lowest rippling problems. And those are typically cohesive gel silicone implants. In addition, saline implants, if there was ever a rupture, unlike the cohesive gel silicone implants, which will hold their form, these saline implants would rupture and the saline would leak out of the implant. The breast would deflate and the body would absorb that saline over time. And so in my practice, for example, I use almost exclusively for the implant-based side, entirely cohesive gel silicone implants.
And that's interesting. I know there's been several times I felt like I've popped something, but I know I haven't. You just wonder. So that takes me into, I know with women deciding to have implants, what does, so two-part question. I guess this first question is very general after reconstruction. What does monitoring and screening look like for women? And then for women who elect to have implants, what does that look like? How often should, in addition to screening to monitor that there's no reoccurrence, what does maintenance for the implant look like? I believe my doctor told me like every 10 years we would need to go back and look, at the implant, and even with fat grafting options. I know sometimes, during my research, you hear that even during fat grafting, that, over time you lose some of that, the fat that's been replaced because you can burn fat. So what does the screening look like after reconstruction to monitor that there's no reoccurrence? And then what does the maintenance look like as far as implants? How often should the implant be replaced, if at all?
So following a mastectomy, theoretically there's no further breast tissue to radiographically screen. So there's no recommendation from a yearly MRI standard that you would be doing for breast screening. The typical screening is done through physical exam. Nevertheless, if you had silicone implants placed, the manufacturers do recommend some sort of screening to ensure the integrity of the implant. That is optional based on the patient's decision, obviously, but they generally recommend an MRI 3 years after the implants are placed, and then subsequently every 2 years after that. Implants today are designed to last a lifetime. However, based on studies, we typically see that the patients that have had implants return for some sort of revisional surgery every 10 to 15 years. This is not something that by any means is, in the past, the older generations of implants, the recommendation was to replace those implants every 10 years. That is no longer the case, and that's it. The decision for any sort of revisional surgery is based on patient preference alone. Obviously, if a patient had a previous breast augmentation and then did not have a complete mastectomy, they had a lumpectomy, they would still need to go through their traditional screening for the implant, as well, in addition to that, their general breast screening, which would be on a yearly basis. So it's important not to confuse those two. The screening that you're doing following a mastectomy is entirely for the radiographic screening, is entirely for the implant.
Thank you so much for sharing that, and also for clarifying that. I know as patients and caregivers and family members, we're reading so much, and I think it's so important that that we have those questions answered. This is a pivot. Are there any new reconstruction options that we should know about, including any clinical trials?
In terms of reconstruction options, well, the envelope is always being pushed a little further for the benefit of our patients. So there's never a good time to have breast cancer or to have a genetic mutation that can cause breast cancer. But that being said, we have never been more advanced than we are today in our treatment of breast cancer and our reconstructive options. In terms of autologous or using your own tissue options, newer flaps are being developed and popularized. For example, the PAP flap, where tissue is taken from the medial thighs, has in recent years become more and more popular as a secondary option if people don't have sufficient abdominal tissue or they've had previous surgery that precludes any option for a deep flap. Like I mentioned, implant technology is getting better and better. Fifth generation implants have never been as good as the current implants that we have on the market. And then the next frontier really in breast reconstruction and also in breast surgery is nerve preservation. And so that's kind of the new frontier for us to explore. And we're very early in that progress, and early studies have shown modest improvement in restoration of sensation. So not only in terms of in nerve preserving surgeries for mastectomies, but also in nerve reconstruction, where we can harvest or neuritize tissue taken from the abdomen, where we can hook up the nerves with the perhaps theory that sensation can be restored in the breast. Early studies have shown a modest improvement in this, and it remains to be seen whether this kind of expertise is going to continue to advance. But this is what we see as the next frontier for women because breast restoration is not only in just the natural appearance of the breast, but it's also in the sensation.
In the sensation. No, that's huge. I know over the last 7 years, naturally, I've slowly received some sensation, not full, but I've been able to tell the difference. And to your point, that is definitely huge, especially emotionally, and mentally too. And while I can't speak for all women, just being able to have that sensation back. So I know I definitely look forward to advancements and updates in research as it relates to that. I have two more questions for you. And this is a question that I hear a lot. I know that's asked a lot. What are the reasons for and against having immediate reconstruction versus waiting or delayed reconstruction as at the same time of cancer surgery?
So it's a really good question. I think in general, immediate reconstruction leads to better aesthetic results as a whole because you're removing the breast, taking advantage of the fact that the skin is still there, and you're replacing the breast with either a device like an implant or a tissue expander or your own tissue. That being said, immediate reconstruction is not always an option for people. For example, in patients that are a high likelihood of needing adjuvant radiation, we typically don't want to reconstruct the breast and then have that breast that's been reconstructed radiated and all the impacts of the radiation on either the implant or on the tissue that we just transferred there. In those situations, a delayed reconstruction is preferable because we allow the radiation oncologist to radiate and treat the cancer area. And then we want to bring in typically non-radiated tissue to restore the breast. And so in those situations, a delayed reconstruction is preferable. But as a whole, if there's an option for an immediate reconstruction, we counsel patients that those typically give better results. But there's many patients that may be overwhelmed by the diagnosis. They don't know if they want reconstruction. In those situations, those patients may want to delay their reconstruction and so that they can overcome both psychologically and physically the cancer treatment before making that decision.
Thank you for sharing that. I heard you say a couple of things, and one thing that really stuck out was, and that really takes me into my last question, is that the social and emotional part of this journey. As I shared with you, I am undiagnosed. My great-grandmother, my grandmother, and my mother all lost their life to breast cancer. My father is a prostate cancer survivor. And so this is something that is really near and dear to my heart and drives my passion and my work as an advocate. But it's also in this journey of being an advocate, the social and emotional part of a woman's journey is huge. Dr. Wintercore, you are an expert of the science and the knowledge, and women, they're the expert of their lived experience and of their bodies. And it takes both coming together, having those shared conversations, having those collaborative, bi-directional, ongoing conversations to be able to know that we're not only meeting the needs of that woman, but also, like you said, we're removing the cancer from her body. And so my last question is, and it's maybe just kind of your thoughts, knowing that women are impacted by this with, struggling with sexual and intimacy challenges, not being able to breastfeed, and just, being able to readjust from being diagnosed to now having the decision to be aesthetically flat, or having the decision or making the decision to have reconstructed breasts. What would you say, or what do you share with your patients as it relates to just affirming them and reassuring them and empowering them as they go through this journey with their decisions?
So I think having empathy and compassion for what they're going through is the most important thing. I think recognizing that sometimes the cancer diagnosis doesn't hit them until the end of the journey, which is often the breast reconstruction component. It may be years later after the cancer has been treated that the overall impact is felt psychologically for these women. I've had a number of women in my office cry for the first time after having breast cancer, years after they underwent chemo, radiation, breast cancer surgery, because it's at that point they're only coming to grasp with what has happened. And you have to be, as a plastic surgeon, you have to be aware and in tune with these, when, or at least the timeline of when these emotions can hit. And that really is, it can be really, really late. I work with a body image specialist who is a psychologist who works with these women to just for somebody that can understand and spend the time to talk to them and even to connect them with other survivors or survivors that have gone through those experiences, because sometimes being able to relate to other women is really impactful in understanding your own disease and that you're not alone. Because the reality is 1 in 8 women get breast cancer. This is a very common problem. Yes. And so I think first one, recognizing what they're going through is first and foremost, for me as a provider, the most important aspect of treating women with this type of disease. But then the second thing is being able to connect them, reassure them, and with the resources in the community that can help them long term, because they're going to be living with the consequences of the cancer treatment for the rest of their lives. And it's important that they have the resources available to them to reach out and know where to go when they need it the most.
Absolutely. And thank you for your compassion. It's so important to have a doctor, a care team that is compassionate. I definitely believe in the value of having breast navigators and social workers and mental health providers to be able to help women and their families through this continuum. It's just as important as treatment. And so thank you for your compassion. Thank you for providing those resources to women and their families as they navigate this journey. And you're right, with some women, every woman processes their journey differently and at different times and at different ways. And I had heard a woman, she was undergoing a mastectomy, and I love the way she put it. She said, I had to grieve my loss. And she said, I lost my breast, and so I had to grieve. And that was a process she was going through on her way to healing and on her way to recovery. And so that really just stuck with me, because when you lose someone, you grieve, or when you lose something, you grieve. And so she grieved her breast. And that helped her to really process her feelings and emotions, and navigate and really explore and lean into how she was feeling during that process. And so I want to thank you so much for your time. Thank you for your expertise and your commitment to women and patients and their families and their caregivers. I want to thank the Alamo Breast Cancer Foundation for being that trusted resource for women and patients and families to go to be able to educate themselves and equip themselves with the tools and resources so that they can be able to make informed medical decisions in collaboration with their providers. So, Dr. Wintercore, as we close out, any last words, anything that you want to share?
Well, I think you've been very very humble about your experience. I'm sure somebody in your shoes can really appreciate asking these questions, having gone through what you've gone through. I think you've been very comprehensive in the questions that you've asked and very diligent. And hopefully, this will be an opportunity for patients to look back at this video and really understand, or perhaps have some of their questions that they did have unanswered, answered, and be able to understand what they're going to be going through or what they've gone through better. So thank you for doing this, and thank you for having me on.
Thank you. And I always say our paths are different. Our goal is the same, and that's to live and thrive. Thank you, Dr. Wintercore.
Thank you. Take care.